talk a little bit about the research to your understanding of dry needling. It may be that dry needling in some of these studies was thrown at a category like low back pain. And so because it's not, there's minimal to no selection process of identifying who out of that group of patients shows some clinical reasoning to suggest that they might do well from dry needling, and therefore maybe any poor response that we might throw in the face of a dry needler may not have much merit because it shouldn't have been conducted in that way anyway. What do you understand the research to show?
Yeah, so way back in the 90s, DeLito and Dick Earhart and people at the University of Pittsburgh looked at treatment by classification. So when you classify the condition, you have a specific treatment attached to that classification. It tends to be much better than just throwing something at the patient, hoping that they're better. So I think their work is foundational towards, and MDT is very similar in that if you are adept at finding the chief impairment, arriving at a classification, you treat according to that classification, the outcomes are going to be favorable. I think the same would be true for dry needling. If you find in your thorough exam that impairment stands out, so when you palpate and find an active trigger point, it reproduces the chief complaint, and of all your tests and measures, that's the one that stands out to the greatest extent, then you direct the treatment accordingly. I bet it's going to help the patient. Mm. Now, if you go through your exam and you never test a trigger point, then you can't consider that. If you find it's a latent trigger point, it may be something that's going on, it's not why the person's walking in necessarily, and you treat that, it's probably not going to be as effective, right? Joe talked about chronic pain and how he uses it as a means to address peripheral sensitization. That may break through that pain cycle in that particular individual, but then you have many people with central sensitization have high fear, so they don't want to be stuck with needles. And, is that going to be the ideal treatment for that patient? So movement safe pain and some of the work that's done at the Shirley Ryan lab that Annie O'Connor and Melissa Kolsky have done, that subclassification of chronic pain into affective, motor autonomic, and other central sensitization subgroups leads, again, a specific treatment for a particular intervention. So if you aren't using any yellow flag tools, then you're not identifying chronic pain. And then if you're not testing for trigger points, then you're not considering that as part of chronic pain management. We know MDT has an impact on chronic pain population of people with chronic pain. So, that self-management strategy and empowerment, can go a long way towards breaking through that pain cycle when combined with movement safe pain and pain neuroscience education. So I think Joe was talking about that subgroup of patients being ones that he may tend to use more dry needling on. He thinks that in many cases it's overutilized, but he sees it among skilled clinicians as being appropriate in a certain subgroup of patients. I think the question is, what is that subgroup of patients? What do they look like? Yeah. They're ones who maybe are more chronic, more adaptive shortening, movement around, improper joint axis, like Shirley Sauerman's work. They're not responding to repeated end range. Their joint mobility may be okay. They may be hypermobile, but it may be okay. Could be excessive in their guarding and protecting and developing a trigger point that way. And now they have this active trigger point, and that reproduces that pain that they're most familiar with, their concordant pain or asterisk sign or whatever you want to call it. Then I think that might be very effective in that particular subgroup of patients. So I think the key is in the challenge to all of us is, what are those subgroups of patients that are most responsive to the things we can offer? So if a physical therapist can do dry needling as opposed to someone seeing an acupuncturist, and that trigger point is the reason why that person's in to see us, I'm in support of that. Would it be what I would do? I mean, I'm not even trained in it, but I would say that again, I'll say this to our colleagues: if we don't test for something, then we're not even going to address it, not even going to consider it. It's not up there. if we're not going to assess for joint play or joint, whether, doing a vertebral pressure provokes the chief complaint, we don't assess for that, and we don't know. So maybe that person can get to end range to address that chief complaint through their own volition, or maybe they need to have joint mobilization till they can get to end range, right? So that's part of the MDT process.
Yeah.
Maybe taking it a step further, and again, I don't want to speak out of tune here, but maybe they need to address that trigger point and then do muscle re-education. And now they can move to end range to address the reason why they're there. So we know, second to derangement is the other classification. Maybe there's a population of patients that fit other that should be considered.
Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.